Thank you, Marty. It's a really privilege to be here. Actually, I've wanted to come to Vancouver for about 25 years. I was just saying that when I was at medical school in Glasgow in Scotland, one of my best friends was from Vancouver. We played Canadian football together, and he was a big 6'6" kind of guy, and it was hard to throw the ball longer than he could. But I did now and again. But it was fun. So we wanted to come here for a long time, and Marty probably doesn't know, but actually he has influenced me quite a bit because I worked with a guy called Tony Tolcher for 3 years in San Antonio, and I heard all about the Shinogi model and BCL2 antisense and all this kind of stuff when I first went to San Antonio, where I guess my interest in prostate cancer drug development was actually sparked. So thank you, Marty, and your team for all that you've done in really moving this field forward. You've really been, a key leader in the field. So I just want to share with you what's, I guess, happening in the field. I guess you know a lot of this, and I'd really like you to stop me as I go along. I want this to be a dialogue. I mean, you've heard this kind of stuff before, probably most of you, and if you haven't, well, I guess, what you can ask me questions at the end. We've seen a significant change in prostate cancer therapeutic landscape in the last 3 years, with 5 positive randomized phase 3 trials, with the first being Sipuleucel-T. Then we published the cabazitaxel data with a survival benefit in that study in the Lancet. Then we had the abiraterone data. And then we had the alpha-radin data. That also came partly from my institution with Chris Parker, my colleague leading on that. That paper is just being submitted. And most recently, the MDV310 data is really Mike Jung and Charles Sawyer's work, but I helped lead the phase 3 with Howard Shear. So 5 new drugs, and with docetaxel we have 6 drugs that improve survival in prostate cancer. So how does this influence you and me? Well, I think what it does is it increases complexity. If you're a urologist, it certainly changes how you name the disease, how you actually write your letters. I have had to educate my colleagues to stop using words like, maximal androgen blockade. I don't know what that means anymore. I think we have to rethink how we define castrate hormone levels. What does that mean? I think that cutoff was really an arbitrary definition that perhaps is not fit for purpose anymore. But I think most importantly, these trials have changed how we think about prostate cancer biology and about targeting the androgen receptor. So I'm unashamedly going to focus primarily on the AR today. I have to be honest, I was scrambling last night thinking, what am I going to cut out and what am I going to focus on? I could talk to you a lot about cabazitaxel, alpha-radin as well, but I think probably more salient for a urological audience is the drugs that are targeting the AR. What you will see at ASCO this year is the pre-chemotherapy abiraterone data, which I cannot present with you, although I'm very familiar with the data, but it is very likely that that data will influence the movement of this drug into the pre-chemotherapy space, which I guess is the space where you as urologists will be very interested in involving yourselves in patient care with that drug. The question is, how are we going to sequence these agents? How are we going to maximize patient benefit? The honest answer is, we don't know yet. But I can give you some indications of what I think, although what I think may not be entirely correct, although further studies are needed regarding optimal sequence of these drugs, and particularly the study of these drugs in combination, for example, abiraterone and MDV. We've just published a paper in Cancer Research you may have seen supporting that combination. So I think the landscape has changed substantially. We'll have to look at what the MDV310 data does with regards to pre-chemotherapy, the pre-chemotherapy trial Prevail. But I guess it's a bit like chess, So you play your move, and you have to see what the opponent plays back before you see what's going to happen next. And the question is, are we thinking strategically enough as to what's going to happen 3 or 4 or 5 moves down the line? I am very excited about the new drugs that, Marty and you've been developing with regards to the antisense. Amin has been very involved with drugs like the HSP27 inhibitor and the cluster antisense. I think these drugs have great potential, but I think the changing landscape is making it a bit more complex to develop these agents, although I think develop them successfully, I'm sure we will. Okay, so let me try and start getting into the slides. These are, sorry, I should talk about my disclosures. So, abiraterone was actually made by chemists at my institution some time ago, and I have served as an advisor or consultant for Cougar, and that was unpaid. For J&J, that was paid, but also for many other companies, including Astellas and Medivation. And I'll be talking about MDV3100 and abiraterone primarily today. Okay, so unprecedented progress. Do you know about these drugs? These trials have really revealed insight into biology. And I think the reason I keep on putting this slide up is that I'm concerned that in this disease we are not stratifying patients molecularly. And you may have seen a paper in the New England Journal from my colleagues in London at my institution, Gerlinger et al. In the New England Journal. And the complexity of intra-patient molecular heterogeneity and inter-patient heterogeneity is like a specter for us in our clinical trials. This is one nut we have to crack, and probably the most urgent issue for us in prostate cancer therapeutic development and treatment development. So I think the insight into understanding carcinogenesis and androgen receptor-driven double-strand breaks through topoisomerase 2 beta, probably initially through the chronic inflammatory process that has been described by the Hopkins group, and maybe an early effect on DNA repair, leading to the formation of these double-strand breaks. That then leads to the rearrangements that Arulchinian's group have actually identified. So one key issue for us as we think through prostate carcinogenesis is, what are the earliest events in this disease process? And for me, one of the key issues is that is there a DNA repair defect that actually predates these rearrangements? Or is it mainly that the rearrangements induce a DNA repair defect and the genomic instability? Or maybe it's both. And I think this is going to be quite an important thing to figure out. As you may know, the AR-driven double-strand breaks induce these translocations or rearrangements of ERG, ETV1, ETV4 that Arulchinian's lab described, that results in the hormones hijacking these potent household switches to become oncogenic cancer proteins. And I think there's going to be a lot of excitement as drugs are developed to target these challenging protein-protein interactions of these oncogenic transcription factors. But I guess the key question is, what targets do we go for in prostate cancer drug development as we look at the increasing complexity of our understanding of the biology? Other than the H genes, what else should we target? We're focusing quite extensively on the PI3K/AKT pathway. We remain very excited by the heat shock proteins. We have a major interest, like you, in that area. But I think beyond that, where do we focus on? And I think maybe our genomic data will actually guide us as to what we need to prioritize. Although I'm concerned that the intra-patient genomic heterogeneity, particularly as captured maybe in part by Gleason and his Gleason grading, and maybe through polyclonality, through field effect in one prostate cancer in different clones rather than subclone selection, may make interpretation of that genomic, next-gen sequencing data quite difficult.
Johann, I'll just interject with, I just came back from a lung cancer ad board where that field is convinced that you have to biopsy every patient ahead of time and then direct treatments according to mutational status, and they've had some success in that regard. So why can you do that in something like lung cancer, or are they actually drinking a Kool-Aid that maybe they shouldn't be, whereas in prostate we can't?
So actually I'm just writing a grant on this, so I think the key issue is that identifying the what's maybe best described as the trunk mutations. So if you think about cancer biology like a tree, okay? So you have trees like, palm trees, one long trunk and a few palms, coming out. And that one long trunk is the first mutation or genomic aberration. And then downstream you get a few other changes and you get cancer. Or you can get, trees like in the African savanna where you have these boa trees with just complex, chaotic branches coming out everywhere, or trees in between, a beautiful oak tree with branches, and you get one trunk mutation, and then clones evolve in this phylogenetic, evolutionary, Darwinian, fashion. And I think what would be, quite important for us to start looking at is what is generally that, that very first, or one of the very first, really addictions to that disease. So to answer your question, I think the limited success they've had in lung is probably because they've generally hit, driver-addicted trunk genomic aberrations with, for example, mutant RAS or mutant EGFR. But I'm concerned that actually if we start looking at next-gen sequencing genomic data from one biopsy, that we will actually miss a lot of the complexity of the tumor landscape, because there is genuine subclone and polyclonal complexity in prostate cancer. Gleason captured this by going for 4+3 or 4+4, two the commonest clones that you can see in a prostatectomy. So I think studying intra-patient heterogeneity is going to be very important, looking at multiple biopsies, and perhaps by doing a phylogenetic construction of that heterogeneity in the patient, you can now identify what's the trunk and what are the peripheral branches. And what that paper in the England Journal of Medicine in renal cancer from our my colleagues at the Marsden showed is that there is quite a lot of convergence. So actually the early events is quite common. Maybe ERG is quite an early event, but maybe not the earliest. But some of the later events, like the PI3K-AKT pathway changes, can happen quite late. And you can abrogate, you can hijack that in different ways, in different clones, but you actually converge later on in different clones, in different ways to activate that pathway. Sorry.
Did the number of biopsies influence your chance of making that decision?
Well, in clinical practice, are you a clinician? Sorry. Okay, so in clinical practice, and I'm a clinician like you, I think that if we did fewer biopsies, as we used to do in the olden days, we often missed the clone of maybe aggressive disease that could kill the patient. I guess you could upgrade based on getting more tissue, and this led urologists, and I'm not a urologist, although my father-in-law is. That's the best I could get, but she's a great wife. But I guess understanding that complexity in a patient's prostate is really quite important. I think. And I think the key issue is going to be how important is polyclonality compared to subclone evolution, and can we better characterize the key driver aberrations through studying intrapatient heterogeneity? I think we will, the problem is, okay, you do one biopsy, okay, fresh, you do deep sequencing, whole genome, you pull out 300 genomic changes. How the hell do you do functional evaluation of 300 changes? How do you know what's key? You've got no idea. And I'm being conservative. 300, I mean, that's probably, optimistic. You get 1,000. How do you figure out which of those is key to driving that cancer, and what you prioritize, and what combination you prioritize? And if you start talking about combinations, you start talking about, the power of, 6 or 10 different variants, yeah? So I think it's going to be quite challenging to interpret that data, and I think studying interpatient heterogeneity may allow us to actually reconstruct the evolution, the Darwinian evolution of that disease, and maybe determine what is really key to that.
I have one last question: as urologists, we tend to think about biopsying the prostate, and then how does that predict for the lethal component of the disease?
Absolutely. So I'm assuming that we're on the same page here. We're talking about biopsying not only the prostate, but obviously Mets. And actually, I could show you some nice pictures, but I didn't have time to put all my slides in. But we're now trying to routinely biopsy all our patients, and in our phase 1-2 trials, we're trying to biopsy all our patients pre and post therapy. Now, to be honest, it's really quite challenging trying to decalcify, bone biopsies. It's a pain, but we're trying to do it. We're doing it as minute. We do about 4 or 5 or 6, bone biopsies a week in our CRPC patients. My staff used to hate it, but they've got used to it. So, I think we have to go like our myeloma colleagues have done. If we really want to change it for prostate cancer patients, we've got to do it. I don't like doing it. My staff don't like doing it, but we've got to do it. The question is, have we got the balls to do it? Forgive my language, We got to do it. Otherwise, we're not going to improve outcome, But I think that polyclonality against interpatient heterogeneity at a uniclonal or monoclonal evolution, subclonal evolution issue, you can be interrogated in part just by looking at prostate biopsies. And I think that if we look at whole exome or whole genome evaluation, that might give us some clue onto that phylogenetic evolutionary tree and what's trunk and what's peripheral branches. So I think that merits being done as well, and we're trying to do that in my center. Okay, so I didn't mean to go there, but anyway. Okay, that was quite an interesting discussion. Anybody else wanted to talk about that? Because I'm not going to come back to that later on. So, any other questions on that?
Have you looked at any metabolomic endpoints?
Thank you. So I have colleagues in my group or our institution that I work closely with, and one of my fellows is actually doing a PhD in that group, looking at metabolomic biomarkers in plasma. There's a lot of noise. There's diurnal variation, for example, food effect, and once we establish what's noise and what's real, it's going to get easier to use that in the clinic. I have not at present done any metabolomic work in clinical trials, prospectively, although I'm retrospectively collecting samples that are being analysed in that lab. So, like others, we've been looking at p10 loss and looking at erg rearrangements and metabolomic profiles. I think the noise is actually quite difficult. And at this juncture, how should I put it? It's maybe not what I see as low-hanging fruit, but I think it's worth pursuing. We're very focused on looking at nucleic acids in plasma, circulating tumor cells, and I think that is probably what I would call lower-hanging fruit. But I think it's important to study metabolomics. So, but it's not my expertise, to be really honest with you. So, okay, anybody else? Okay. So what about improving treatment and changing the landscape? So until 2010, we really only had docetaxel and I guess castration with other agents, including bicalutamide and flutamide, having minimal impact on patient outcome. And certainly in our institution, what we did was we used all these drugs like diethylstilbestrol, 50 mg of Casodex, 150 mg of Casodex, and dexamethasone, stilbestrol, and you often saw patients benefiting again and again. So when I left San Antonio in 2003 to go to London, I found out that my former colleagues at the institution who were just retiring, Mike Jarman, a guy called Jerry Potter who's been unwell, and the girl called Elaine Barry, a lady called Elaine Barry who's actually soon retiring as well, had made in the early 90s this drug called abiraterone. So I tried to take that back to the clinic, which, as you know, we did. But we also did a lot of work on HSP90 inhibitors, HDAC inhibitors, which are all published. And we saw some activity with both. And in fact, with the HSP90 inhibitor, we had a complete response with 17 DMAG that went on for about 15 to 18 months. And a further benefiting patient on study for over a year with no radiological measurable disease. But anyway, that's a different story. So what we did was we took abiraterone. Actually, he was a Canadian, wasn't he, Huggins, I think? Yeah, so.
The other two, Charlie Huggins, who went to
Chicago, yeah.
He went to Portland. The other guy is Bill Scott. He was a med student. He was my professor.
Okay. Were they both Canadians, were they?
No.
Huggins is Canadian, yeah?
But they all came to Hopkins.
So where was Huggins from in Canada?
Nova Scotia.
Okay. Okay. No Scottish roots then.
But he was at Chicago when he did the work.
Yeah, I know that, yeah. But you can be proud he was Canadian, so.
He was proud he was Hopkins.
Okay, so this was our hypothesis in 2004. I guess you noticed there was a lot of evidence for continued AR signaling in this disease, which I guess you all know. Work from Jim Moeller, Labrie a long time ago in the 80s, another Canadian. And work from Charles Soares, particularly in 2003 in Nature Medicine. And then our rules data really were pretty convincing that this disease remained hormone-driven. So we took abiraterone to the clinic, and the rest, I guess, is history. Abiraterone inhibits hormone synthesis in the testes, adrenal gland, and prostate tumor cells. And I think the latter, the prostate tumor cell intracrine synthesis, as you have elegantly published through Jenny Locke's work and other papers, is probably quite important in the mechanism of action of abiraterone, although it's hard to know exactly how important that is. We showed in, I guess this is the structure of the compound. Interestingly, urologists were quite important for the initial screens. So the screens were done on prostate cancer, human human testicular lysate screens. So they actually got they castrate patients, got the testes, mashed up the testicular tissue, and actually did assays on CYP17 with radio-labeled substrate for the enzyme, with the readout being a simple HPLC assay on radio-labeled product. So it's a functional, assay on the testicular lysate, which is actually quite interesting looking back. It sounds a bit crude, but this is quite a long time ago in the early 90s. Anyway, this is the drug that they discovered, abiraterone, which you know about, and it inhibits CYP17. And I think the one thing I can take credit for is that I could remember from my physiology days in medical school, physiology was a particular strength for me, was that actually there were kids that grew up without this enzyme and they never got adrenal failure. And actually an important pharmaceutical company owned abiraterone for quite a while and refused to develop it. And I think they missed out on a lot of money. And eventually Ari Veldegren was smart enough and clever enough to actually raise funding to in-license or out-license the drug from us. We out-licensed it to him to develop it to Cougar. And actually when I wrote the first phase 1 study, Cougar was a 3-person company. One was Ari, who was a professor in UCLA, and he deserves a lot of credit. The other one was a Chinese lady called Gloria Lee, who had never really written much of a phase 1 protocol before. And the third person was a Wall Street banker called Alan Auerbach. And that was Cougar. So, any of us can do this. It can be done. So, and Ari made a lot of money along the way, I guess. So the drug inhibits that enzyme. What it does result in is what happens in these kids that lack the enzyme is a fall in hormones, testosterone and estradiol, with an increase in ACTH through the feedback loop and upstream hormones. Importantly, the corticosterone upstream of the enzyme results in no risk of adrenal insufficiency. Can I say that again? Abiraterone cannot cause adrenal insufficiency unless there is pituitary failure, in which case you'd have seen that in the first place before you put the patient on trial. Now, I have to say the IRBs in the US didn't get this, and the reason I was able to steam ahead with the trials, because our trial ran in parallel with the UCSF trial, phase 1 trial. They were delayed by about a year because the IRB just didn't get this, and were worried that inhibiting this enzyme would cause adrenal failure. But what these kids do get that lack this enzyme is hypertension and hypokalemia, and most importantly, a delay in sexual differentiation because of the lack of hormones. Okay, so you know the rest of this. I should say that we're now studying abiraterone in breast cancer. I'm getting quite excited about abiraterone in AR-positive, ER-negative breast cancer. And I can't talk about this yet, but, watch this space. It's going to get quite interesting. Sorry?
Shinogi carcinoma.
Okay.
Yeah, that's true. That is a she.
So, this is patients. We're doing it in patients. We're seeing activity. Okay, so this was a phase 1 study. I guess you've probably seen this. Well tolerated, no dose-limiting toxicity, but good evidence of target knockdown. PSA for me was a pharmacodynamic endpoint, and I didn't see it as anything else in this trial. And that's why we did CDC studies, and we saw anti-tumor activity. And actually, last Friday, one of my patients came to the clinic with a £500 check. I guess it's about 800 Canadian dollars or so, and he's been on the study for 6.5 years from the phase 1. Still on the drug. I mean, he's obviously, one of the best responding patients. But, it just shows you, one of my colleagues said to me that giving abiraterone for him was like restarting, hormone therapy for the first time. And I think, it's just sad that for 30 years, we missed this. I kind of feel looking back, we should have got to this sooner. But hey-ho, I guess, it's easy in retrospect. So, we saw, responses, lymph node regressions, major falls in PSA in some patients by 99%, and falls in circulating tumor cell counts. And this was the post-chemotherapy study that my fellow Alison Reed published, and JCO is first author. And this was with Howard Shear at Sloan Kettering and the UCSF guys. And this led to the phase 3 study, 2-to-1 randomization, prednisone given to all patients. And I should say that prednisone may be a weakness here, so I'll come back to that in a moment. And it showed a random survival benefit. I do think you'll be impressed with the pre-chemo data, and I wish I could show you the survival data today, but I can't. But I think you'll be convinced if you want to see the data after ASCO, it looks as good pre-chemo. So I think that this drug will go into the pre-chemo space. That was the first analysis, which led to unblinding of the data. The second analysis before crossover, I guess, confirmed the findings of a 4.6 month survival benefit. That was actually present across all subgroups. I should say to you that for both abiraterone and MDV, I really couldn't tell whether the patients were on, placebo or abiraterone based on toxicity. And I tried really hard, because actually looking for hypokalemia. But in fact, the frequency of hypokalemia was actually quite similar for the prednisone alone arm and the combination arm with abiraterone. So I think, the tolerability is really quite spectacular. Although if you give abiraterone on its own without prednisone, without a mineralocorticoid antagonist, you will run into problems. And you can kill patients from hypokalemia with abiraterone alone without steroid or mineralocorticoid antagonist. I should say to you that our first trials, our first 54 patients, received abiraterone without steroids. This is a very important point. Abiraterone can and has been given without steroids in some patients for years, 4 or 5 years. And that's quite an important point because prednisone is an AR agonist. Prednisone is an AR agonist. Can activate promiscuous mutant AR. And I think that's a really important point, and it's probably a feature of a mechanism of resistance.
What happens in eugonatic men given abiraterone?
So, there is some data on that from our institution. The very first studies showed that the LH-RH-LH feedback induced by that hormonal deprivation abrogates the impact of abiraterone on CYP17. So basically what that does is a huge increase in CYP17 expression, and that bypasses the blockade, certainly at lower doses of drug. Trials are now ongoing looking at high doses of abiraterone. I remain concerned that it may be difficult to bypass that feedback loop. So I would still argue that the best way to give this drug is probably with LH-RH analogs. But, I don't know. We need more data. And I think those studies are being done and need to be done. So, but I haven't seen data yet, and I'm not involved in those studies. But I know that the urologists in Europe are doing those studies. So. Okay, so the secondary endpoints were in favor of the drug, and these are the adverse events. So basically, really, the placebo arm looked more toxic than the treatment arm. The adverse events of special interest, you can look at the grade 3-4, really very, very low frequency of grade 3-4 adverse events, even in the toxicities that we expected with this drug. For example, the transaminase elevation, which is, people have Cougar made a big fuss about. I mean, I'm not particularly worried about this. In the placebo arm, it's 3%. In the treatment arm, it's 3.8% grade 3-4. I think hypertension can be an issue, and most of the patients that get hypertension have underlying hypertension, so they're known to have hypertension at baseline, and that giving drugs like amlodipine easily manage that, or the mineralocorticoid antagonist eplerenone manage that. Eplerenone is a spironolactone-like compound mineralocorticoid receptor antagonist, but we've just published in Cancer Research that can also activate some promiscuous AR variants. Okay, quality of life improvement was also demonstrated in these trials. A lot of quality of life data. I won't go into these in any detail. And certainly, it was quite spectacular for me to see patients who were, almost really housebound, struggling to cope with daily life, getting back to some kind of normal or near normal quality of life, although clearly the impact on sexual function remains. Okay, so that was abiraterone. Understanding the mechanisms of resistance of abiraterone remains key. I think that, I guess, AR splice variants may be important, AR mutations may be important, that can be activated by prednisone. The splice variants are consistently active, as you may know, lacking the ligand binding domain, so neither MDV nor abiraterone may hit that. But there's more work going on in the area. There has been some data published from the Seattle group and Steve Bolk's lab in Boston that increased CYP17 expression may bypass abiraterone blockade of CYP17 and result in resistance. We haven't seen that in patients. The 2 bits of data that I can share with you is that we have dose escalated patients in a phase 1 study at progression who were never able to see any reversal of resistance. And also the clinical data does not show any evidence of increase in hormone levels either in blood or in the tumor from the MD Anderson data at progression. So it remains an open question, can the tumor evade that CYP17 blockade either through CYP17 mutation, and we've studied that extensively, or CYP17 increased expression. So I don't know if anybody wants to comment on that.
I have a round table.
Yeah, okay, okay. So on to MDV3100. This is the brainchild of Michael Jung and Charles Sawyers at UCLA. Really beautiful story. Look at the Trinital science paper. And there's also obviously the Aragon compound that is almost identical to it, bar one atom in the compound. This inhibits AR signaling at multiple levels, but particularly unlike bicalutamide, blocks AR cytoplasmic to nuclear shuttling, and also does not have any partial agonist activity that we know of as yet to most AR variants. There is some evidence in PNAS that actually MDV210 also blocks the AR splice variants, although I personally am quite skeptical about how valid that data is. But we can discuss that later on as well. The phase 1/2 study that Howard Shear led was a US-led study. Sadly, we tried to run it in the UK, but the regulators actually did not approve it in the UK, although I helped design the trial. But essentially, this trial showed significant tumor activity, PSA, radiological responses, and falls in circulating tumor cell counts. Quite impressive, as you've seen in that Lancet paper. This led to a randomized phase 3 study that Howard and I co-led, international study. Very similar, actually, to be honest, identical design to the abiraterone phase 3, which was used as a template for this trial. 2-to-1 randomization with overall survival as the primary endpoint, and typical secondary objectives, including quality of life data. Okay, and after the 520 events had occurred, 520 deaths at interim analysis, the independent data monitoring committee actually favored stopping the trial, that placebo patients should get the drug because there was significant benefit. Now I must stop here for a moment. These 2 trials are similar but different. So abiraterone MDV. The key thing is that abiraterone was randomizing to prednisolone or prednisone. Okay. This trial randomizes only to placebo. Okay. Now, is that relevant? I think it is, because actually, when I look at our CDC data, I've actually can tell there's a significant CTC response rate as well as PSA response rate to prednisolone alone. And I don't know if you've seen this, but actually, I give a lot of my patients, at the end of life when they failed everything, what I call the SAD regimen: stilbestrol, aspirin, dexamethasone. SAD, S-A-D, stilbestrol, aspirin, dexamethasone. And they respond. They're dying. They've got nothing else left, to go. And you give them, what I call the SAD regimen, and they actually benefit. So I think, the 2 trials are different, and I think that is hard to compare. The other thing is that the landscape had changed when MDV came true. So patients after the MDV placebo, treatments actually got cabazitaxel, abiraterone, maybe alpha-rated. So actually things had changed significantly, and it's hard to compare the 2 trials. But I think overall what you can see is that abiraterone resulted in a 4.6-month survival benefit, and MDV in a 4.8-month survival benefit. So it's actually fairly similar. But I do think it's hard to compare the 2 arms. And the prednisone could be a good thing and a bad thing in the abiraterone treatment, because actually there is toxicity from prednisolone with regards to particularly weight gain. This is in some patients not particularly an issue, but is more of an issue in other patients. I'm also concerned that for some patients, prednisolone may be a mechanism of resistance through iatrogenic activation of promiscuous AR. As with abiraterone, MDV showed survival benefit across the subgroups, as you have seen, and this paper is just being submitted actually just now. And there was a longer time on treatment for the MDV arm, as you'd expect, than the placebo arm. So as I said, the placebo arm did not get anything, did not get any steroids. Now, importantly, as I said, patients after getting this trial got other treatments. So what other treatments did they get? Well, I think the data that has been collected, hopefully it's comprehensive enough, but essentially it seems to be quite well balanced that actually both arms got the same amount of abiraterone, cabazitaxel, docetaxel, but less so with regards to mitoxantrone.
Why was prednisone on? Did you just assume that that's not captured?
Well, it's not on my list of available treatments. So so I mean I think that's a really important point. It's hard to compare these two trials. They're apples and oranges. But I think suffice it to say, both drugs, in my mind, are really spectacularly active drugs against this disease. Another important point actually is that what's quite clear is that both drugs are much more active pre-chemotherapy than post-chemotherapy. I'll say that again. Both drugs are much more active pre-chemotherapy than post-chemotherapy. Now, actually, when I was sitting in advisory boards with Cougar, actually, I have to be honest with you, I argued very vociferously that giving chemotherapy would not change sensitivity to abiraterone or MDV. Okay, I was wrong, but at least I got them to believe me and study abiraterone in the post-chemo space because they were just planning a pre-chemo trial. So I can take claim for that. I was really key to actually take that drug into post-chemo. But actually, giving hormones post-chemo was not the way things were done in 2006 or 2005. But I argue that actually giving taxanes shouldn't change whether cancer is hormone-driven or not. But actually, in retrospect, the taxanes probably are actually targeting AR, at least in part. And there may be some cross-resistance. We've got a paper coming out suggesting cross-resistance between taxanes and AR targeting drugs.
Your median is 4.8, 4.3 months. You've got some guys who are out, they win the lottery, they're out 6, 7, 8 years. Can you identify any clinical parameters? I understand the genetic issue. Any clinical parameters might predict for the lucky guys?
So, I have some guys who are in their 40s with liver mets on trial for 3+ years. We've looked at P10 loss, and Charles Sars is convinced that P10 loss is going to be the key thing. You know what? Some of my best responders have P10 fish minus, no P10 at all. So, at this juncture, the only thing I can say to you is that I'm absolutely convinced that the ERG rearrangement analysis by fish predicts, a better chance of response and better, a longer response. The one thing I can say to you is that we have very strong evidence that if you have high hormone levels at baseline, okay, androgenic steroid levels at baseline, you do much better.
Intracellular?
That's published. No, plasma. So the guys the patients that have high, DHEA, androstenedione at baseline pre-treatment, have a much higher chance of doing well. That's published. We've got another paper coming out on that actually. So that may reflect intracrine synthesis, in the prostate tumor of hormones or adrenal androgen synthesis. I don't know, or some other, organ.
But to get back to your trunk analogy earlier, the ERG rearrangements may be predicting what a driving trunk mutation is. And
Exactly.
Increased responsiveness is because you've got a single sentinel antigen responsive gene now that you're not.
I couldn't agree with you more. And I think that our studies, looking at the archival tissue, the fresh CRPC biopsies and the CTCs, convinced us, and hopefully the community, that actually that doesn't change with time. And, we have actually, to be honest, seen, I think, 2 patients, and we've looked at a lot of patients now, where we have seen intra-patient ERG heterogeneity, okay? So the S gene is heterogeneous in CTCs. But that's out of hundreds of patients. But usually, the ERG rearrangement is exactly the same in every cancer cell. Now, where was I? I can't remember.
But you reported, Gert led a paper, you reported an analysis of a single patient, and you showed that there were different edge rearrangements in areas of no edge.
That's right, in the prostate maps. So I think that's genuinely polyclonal disease. So, I think that in some patients, we generally have intra-patient polyclonal disease. It's a field effect. You have the same carcinogenic insult on prostate epithelial cells. And, in some cancers are going to get the ERG, and some is going to get ETV1, and that's why these prostate maps were so interesting. So the question is, if you're unlucky and you're looking at the biopsy that's hit the wrong clone, hey, you're going to get the wrong prognostic readout, although maybe some patients generally have polyclonal metastatic disease. And I think that's probably likely.
Do you see evidence for that? Because most of the reports are that metastatic disease is
Well, we think that actually very, very rarely that may be the case. That you generally in the CDCs have more than one, S gene rearrangement in CDCs. Am I running out of time?
No. You got
Okay.
10,
Okay, I'm sorry. Yeah.
Go ahead. No.
Okay. So anyway, I'd love to discuss this further because actually, it's fun. So yeah. Okay. So anyway, MDV, impacted PSA, median time to progression. And what's interesting is that for both these hormonal treatments, I think the PSA changes are genuinely a good predictor of activity. Although I have seen at least one patient where they had a spectacular spectacular response radiologically and the rising PSA, and I don't understand that. But there was at least one patient who did really well, radiological response, and a falling and rising PSA.
As PSA and surrogacy.
Okay.
Can you comment on that with these?
So for hormone therapies, I suspect PSA is pretty close to being a good surrogate, but may not make it. My concern is that. Okay, so let me describe a patient. So I've got a patient who I'm currently treating, who progressed in abiraterone with liver mets, without a rising PSA. I knew he was ERG rearranged at baseline in his archival tissue, so I biopsied his liver met. Actually, I bought multiple biopsies on his liver mets. And we showed that there was ERG fish positive cancer in his liver mets. But ERG IHC was negative. So he progressed with a tumor in his liver. There was ERG fish rearranged, but not PSA secreting and not ERG expressing. So, I think my reply is that PSAs are pretty good. But I think this cancer is so smart that it actually can probably rarely, drive the disease without secreting PSA.
Check for rising chromogranin A or something and see your
Actually, we did, and they were negative. Chromogranin A and NSE. And actually, we looked very carefully for neuroendocrine features in the biopsies, and there was none. So that's exactly what I expected, NMIC, etc. But that was not the case.
Grew another trunk.
Yes, sir. I don't understand everything. Maybe that was polyclonal. I don't know. I don't think so. He had ERG fish. So anyway, so this is, and actually it's quite interesting. So maybe hitting ERG will actually, if we start targeting ERG, through Arul's beautiful peptide mimetics, this may actually emerge downstream. Okay. So I don't have to tell you this. So the response rates were better for MDV versus placebo. Not surprising. Radiologic PFS was better. I guess this is actually quite important to go back to the surrogacy issue that I didn't really fully answer. What is the best surrogate for prostate cancer clinical benefit from treatment? It's really hard. We need one urgently. We're working on CDCs, working on plasma tumor DNA. But I think these trials will show that for hormone therapies, radiologic PFS and PSA PFS will be quite, good, maybe not perfect, predictors of clinical benefit. Okay, so the only fly in the ointment for MDV is the seizure rate, and I want to just very briefly touch on that. But essentially, if you look at all the toxicity of MDV, I have to be honest with you, I had no idea it was an MDV on the trial, like abiraterone. The drug is very well tolerated. But there was 5 seizures on the MDV arm and none on the placebo arm for the MDV trial. Now, the seizure rate is less than 1%. It's 0.6% to be precise. And the reason the MDV trial was done at 160 milligram per day dose level was because of concerns that higher doses could actually increase risk of seizures. And if you look at Marco Gottardi's paper, you'll know that the BMS compound also had the same liability, and many of these AR antagonists have the same issue. They get into the brain and actually cause risk of seizures. The Aragon drug is, how should I put it, labeled as being less at risk of that. I'm somewhat, how should I put it, skeptical. Okay, I think the blood-brain barrier is not as easily modeled in preclinical models as you probably know. So yeah, this is an issue. How the FDA will respond to this, I don't know, but it is an issue, particularly if you've got a young man, who's driving. You've got a drug that increases seizure rate. But I should say that for several of these patients, there were that had a seizure. There were other confounding factors, okay, i.e., other drugs, or I think 1 or 2 patients, brain, meds that were getting into the brain. So it's hard to know, but all I can say is that the seizures were only found in the MDV arm, and it's 5 of 800.
There are cases of people having seizures withdraw from Xanax or withdraw from pain management.
But none on the placebo arm. That's the only thing. So I'm not particularly worried about this. Okay, I guess the question is when I'm consenting that patient to go on a drug once it's approved, which I'm sure it will be. If I don't mention a risk of seizures and they fit while they're driving, who's liable? Now I don't know. I think that this drug is a spectacular drug, but I think it's an issue that we have to think about. But maybe as we get more safety data, maybe in patients without these other cofactors, confounding risks of seizures, that we won't see any seizures at all, which would be the ideal thing. I haven't seen any seizures in my patients. I've treated a lot of patients on this drug. Okay, so where are we? So I'm finishing off here. So we have multiple trials now in the post-chemotherapy space. I haven't mentioned alpha-radin, and deliberately. I could talk about that. That was led by Chris Parker at my place. A lot of my patients have had alpha-radin. That's going to get into the pre-chemo space. It's a really good drug. I'm really impressed by it. So watch that space. I really strongly recommend that your patients should get alpha-radin as soon as possible. Patients get major benefit from that agent. And actually the final survival analysis have shown an even further improvement in survival benefit of almost 4 months. So future challenges. So where are we now? Well, I think the abiraterone pre-chemo data presented at ASCO will allow us to say that abiraterone should go into the pre-chemo space. I think the drugs that we've used in the past, i.e., diethylstilbestrol, are going to be difficult to justify. Maybe even low-dose steroids for us will be less used on their own. We are now studying abiraterone in the first-line space in this trial called Stampede that I sit on the trials committee for, which is studying abiraterone in the metastatic disease at diagnosis setting as well as high-risk locally advanced disease. And I'm convinced that that's where this drug will have most benefit for our patients. High-risk locally advanced disease in the adjuvant setting like Herceptin and breast cancer. But I guess after you give LH3 analogs or maybe even LH3 analogs in abiraterone, what next? We're going to have alpha-radin. What about sipuleucel-T? I think I'll refrain from commenting. But I think beyond that, cabazitaxel will probably replace docetaxel in my mind. I think it's a better taxane. I think its toxicity is exaggerated, but I can come back to that if you want me to. And I think there's generally cross-resistance between taxanes and these hormone therapies, which will impact the use of these taxanes in the future in our patient population.
Is Stampede after radical prostatectomy radiation rates?
It's both, sir. Yeah, it's both. Although in the UK we don't do much radical prostatectomy for gleason 8 to 10 cancers, which is a shame for our translation and research. So,
do you have any experience for the sequence of MDV 3100 and abiraterone?
Yeah, I do actually. I've never given MDV after abiraterone, although my colleagues in the US have. But I have given abiraterone after MDV. We've got data on about 40, 50 patients, and the response rate is about 25-30%. But I'm just going to mention why that should work. So give me 1 second. I've got 2 final slides, okay? So we've just published this paper in Cancer Research that is really Gerta Tart's paper. He's the last author, and he's still my fellow, but he becomes faculty in about 6 to 9 months, in December actually, and working with me. So basically, we have shown in this paper that actually increased steroid levels can actually, through stoichiometric competition with AR binding, reverse the impact of MDV on AR signaling. So actually you can get resistance to MDV 3100 by increasing DHT or androgenic steroid levels. Okay. Conversely, we have evidence that the prednisone levels in our patients getting abiraterone and prednisone can actually are high enough to activate promiscuous AR, and that the mineralocorticoid antagonist saplerone that we've also used can activate AR. We have shown in some patients that by decreasing the prednisolone levels in our patients, we decrease PSA. So they're progressing on ABI and prednisolone. I count back the prednisolone dose, and the PSA falls in some of these patients. And that can last in some patients 6 months to a year. So I generally believe that prednisone in some patients, given abiraterone, is driving disease progression. It's an iatrogenic mechanism of resistance. And this is from Gert's paper that spironolactone and eplerenone can activate AR. There's published data that prednisone can activate AR, and the prednisolone levels are high enough to activate AR. And that if you add to your cell lines higher levels of DHT, compete out the MDV impact, or R1881, the MDV impact on AR transcriptional activity in a PC3 PSA luciferase assay. So I think there is merit in studying abiraterone with MDV, and those trials are now starting. So in conclusion, my final slide, I think advanced prostate cancer is not hormone refractory, it's not androgen dependent, remains AR driven. The importance of ER alpha remains to be seen, and ER beta, and I think they are relevant to this disease. Hormone therapy works after chemotherapy, and we should not use the word maximal androgen blockade. I don't really know what that is, so thank you for your attention.